brother's CPK was 380. This is the young man with the myopathic facies and the partial ptosis and the proximal muscle weakness and the cardiomyopathy. We did look at his gene locus because he was interested in the laminopathies, and he did have a mutation in this area. But again, if we look for it, I think we will find it is the answer. But we need to keep looking for these disorders, because there are plenty of these neuromuscular disorders in our country with over a billion population. I can keep on going because we have a huge list, but I think that we have 3 or 4 interesting cases. So I would hope to stop. I mean, these disorders, Ehlers-Danlos and disorders similar to that, are very common again in our country. The clinical varieties are huge. Pursuing a clear diagnosis is not academic. That's, again, many times I'm told by doctors and professional colleagues of mine saying, no, this genetic testing is purely academic. Why would you want to biopsy him or do a gene test? It helps counseling. It helps prenatal diagnosis. It's helpful in prevention of these disorders. And that's the goal, is to try and prevent the recurrence in the same family or their sisters, children, etc. And although there are therapeutic options, a few, but there is a huge, it's important to consider there are huge genetic variables and explosion of knowledge, explosion of number of researchers in this field. And as Satish, Dr. Khadilkar said yesterday, we're all in it together, and it's time that we start networking within ourselves, and we will do it, is the answer, because we are making the initial efforts to do that. We are part of a global initiative to find solace to the families of children with Duchenne and other neuromuscular disorders. I work closely with the Treaton MD and the Synergy, which is a cooperative international neuromuscular research group from Washington. Our sincere thanks to many people, because they have been with us, particularly my physio, Mr. Suresh, and of course my huge number of colleagues of mine who've been volunteering for our MDA clinics. We do have our website here. I'm also thankful to Apollo Hospitals for permitting us and providing us the services and the space for doing our studies. And without that support and without that help, we could never establish research facilities at Chennai. Thank you all, and I think I'll request Dr. Debashish to present the first case. Which one did you want to present? Vijayalakshmi.
The second, third, or fourth will check at the last one.
Right.
Hello everybody, I am Dr. Debashish from Child Trust Hospital. I am going to present an interesting case before you today. A 8-year-old female child presented to us with following complaint for the past 2 years. She had history of frequent fall on and up, inability to get up from lying down and squatting position, and difficulty in climbing stairs. His perinatal history was uneventful. It was a normal delivery, and there is no issues in the immediate neonatal period, and all early developmental milestones he has achieved in time. When she came to us, we did a physical examination where the higher function was normal, all cranial nerves were intact, and the motor system examination revealed a proximal weakness, as his power was around 3 or 5 in the proximal muscle group, and all of the examination was almost normal. His DTR, the knee, ankle, and the upper limb reflexes were present. The superficial reflex, plantar, bilateral flexors, and abdominal reflex was present, and there was no calf hypertrophy. She also had a lumbar lordosis, and her Gower sign was positive at that time. This is the pedigree for the child. This is the black one is the index case, and his and there was no history of involvement any involvement of neuromuscular disease in his maternal side, but his paternal side his father, 2 brothers and 1 sister had some difficulty in walking, but they were not so much affected, but there was some difficulty in walking, and none of the other family members were infected, and the child was born to a non-consanguineous parents. Then we did our initial investigation, which showed a CPK of 12,560. Echo was done, which was completely normal. The nerve conduction study was normal. The EMG was done, that showed a myopathic pattern, and other investigations were also normal. So we thought this may be some neuromuscular disease, and we did a muscle biopsy of the child. This is the muscle biopsy finding in the hematoxylin eosin stain.
Now, what you see here is the muscle fibers. I showed you how the normal muscle fibers are polygonal and opposed to each other, equal diameter. And on the contrary, what has happened here is you have some fibers which are very large, extremely large hypertrophic fibers. There is variation in the size of the fibers. These could be increase in collagenous tissue. There is enormous increase in collagenous tissue. There is also adipose tissue infiltration. And there are a good number of these small fibers in between. So if you have a picture like this, it points towards a muscular dystrophy. And you have done the other scans. This is a better section where you can see the features properly. The large hypertrophic fibers that several internally placed nuclei. This is a fiber which is undergoing splitting. You can see the split here, and these are the numerous small atrophic fibers. So, and of course the adipose tissue infiltration. So this is a muscular dystrophy. On biopsy, it is a muscular dystrophy. Now, what form of muscular dystrophy? You need to do the panel of all the stains for the various proteins. This is for dystrophin, and as you can see here, the labeling is not there on the fibers, so there is absence of dystrophin. This one is for the rod domain of the dystrophin. This is dystrophin 2, which is the C-terminal of the dystrophin. That again shows absence. And this is for the N-terminus of the dystrophin, and that also shows absence. Another field, I guess, the same absence of dystrophin. Okay, then the other immunos. So you know there are absence of dystrophin for all the 3 domains, the rod domain, the C-terminal, and the N-terminal, which is represented by 1, 2, and 3. And this is for the sarcoglycans, the other forms of dystrophin-associated glycoproteins. One of them is a sarcoglycan. So this is for alpha-sarcoglycan. You can see the labeling along the membrane. So this is preserved. This is for beta-sarcoglycan. This again shows preserved labeling along the membrane. So there is no deficiency of beta-sarcoglycan. And this is for gamma-sarcoglycan. Again, you can see the preservation of the protein along the membrane. And merosin is also preserved. Okay, so the muscle biopsy, if you summarize the features of muscle biopsy, you have the dystrophic features, and when you do the protein analysis for this particular case, you find that dystrophin is totally absent, and of course the other sarcoglycans and the extracellular protein merosin is well preserved. So based on this, you can offer the diagnosis, and by this, you offer the diagnosis of a Duchenne muscular dystrophy. And he'll discuss the rest of the...
Thank you, madam. So now the muscle biopsy findings suggest a Duchenne muscular dystrophy, but this is a female child, a 8-year-old female child presenting with proximal myopathy, and we got the impression of Duchenne muscular dystrophy from our muscle biopsy finding. So we proceeded to a genetic analysis, and this MLP analysis for the DMD gene was done. There is 79 exon by MLP analysis shows normal. The patient is not a carrier for any deletion in the DMD gene. Then we proceed to do the karyotype analysis of the child. The karyotype shows a chromosome analysis using GTG banding suggestive of derivative chromosome X resulting from a translocation between X chromosome and the chromosome 3. So, coming to the discussion.
I mean, this is I just thought we'll put it up because, you know, we talk about how females don't get Duchenne muscular dystrophy. Professor Matthews, any your comments on that? Or?
It's coming, sir. It's welcome.
One. First of all, I was going to say that this is an example. You know from the early presentation that this girl had a CK of 1200, so you know that you're looking at most likely a membrane-associated disorder of membrane-associated muscular dystrophy. So then it's going to be either one of the dystroglycanopathies, Duchenne, or one of the sarcoglycanopathies, almost certainly. So when we got and I was betting on a sarcoglycanopathy until I saw the immunohistochemistry, so very helpful. When I saw the immunohistochemistry, then there are basically two mechanisms that you can have a manifesting female carrier. So if you have a girl who looks like she has Duchenne muscular dystrophy clinically, with three mechanisms. One, you can have skewed X inactivation, usually with just skewed X inactivation where the Lion hypothesis just by chance inactivated the abnormal X less commonly than the normal X, then you will not have as severe a case as the one that you presented. You can have XO, and that was the other thing that I was sort of wondering about, is whether this was, in fact, a girl with Turner syndrome. If a girl with Turner syndrome has a mutation in dystrophin on the remaining X, then she will look exactly like a boy with Duchenne muscular dystrophy. And then the third option, which is more rare, is that you can actually have a mutation in the X inactivation center. And so if you have a second mutation, you have a mutation in the X inactivation center, and you have a mutation in the dystrophin locus, then you can have it can look exactly like an XO, because you can have markedly skewed X inactivation.
Any other suggestions? Anybody, any comments? If not, do you want...
DMD can present with Turner syndrome or a skewed inactivation, that is the non-random inactivation of the normal X chromosome. When we went through the literature, there are few cases reported where a translocation between the X chromosome and the autosome has resulted in a picture similar to DMD in a female child. This was a case reported by Petrica A, where a translocation between X and chromosome 5. And another case reported where there is a translocation between X and again X and autosome 5. Another case reported where female child there is a translocation between chromosome X and chromosome 9. So this might be another case of this is a translocation with X and some autosome may result in clinical picture that is similar to that of DMD in this female child. Thank you.
You just present the case first. Which is what? Kavya?
Good morning, everybody. I'm presenting a 6-year-old female child who was referred to us with history of pain in leg on and off since the last 2 years. She had intermittent pain, usually in the evening. So, and there she was investigated and her CPK was 11,130. So she came to us. On history, she had no antenatal and perinatal complications. Development milestones were normal, appropriate for age. Her pedigree analysis shows that she was 4th in order and her mother had had 2 abortions. She was a product of non-consanguineous marriage. On examination, this child was alert looking, oriented, studying in UKG, normal built. Power was grade 4/5 in all limbs. Govers were negative. DTRs were present. plantars were flexors, we can see the calf muscle hypertrophy and it was non-tender. This is the girl. So we investigated her. Her reports were almost normal. CBC RFT was normal. Her CPK again was 6,393. Transaminase levels were raised. Other than that, LFT was normal, echo-DERN was normal. So we proceeded for a muscle biopsy. So we have a girl with with pain on legs on and off since the last 2 years, with calf muscle hypertrophy and raised CPK. This is the HNE stain. Ma'am will tell us about it.
Do you want to describe? Now, here, this is again a transversely cut skeletal muscle tissue where you can see the polygonal fibers. And the only feature that you see in this field is very mild variation in the fiber size. Otherwise, the other fibers appear normal. The nuclei are all peripherally placed except for one with centrally placed nucleus. Now, this occasional fiber with central nucleus can be normal. In a given muscle group, up to 3% of the fibers with centrally placed nucleus is considered to be normal. So this is what you see. Except for mild variation in the fiber size, there is no other pathology like you saw in the other slides of the previous case. Now this is the ATPase reaction, which gives you good checkerboard pattern, except for one area where you have mild grouping or the light fiber. This is on pH 9.4. Then these are all the type 1 fibers which are slightly grouped. But this again is a normal feature. It is called not exactly grouping but enclosed fibers, where you have one fiber of the same histochemical type being enclosed by the others. The mosaic pattern is well maintained in the rest of the areas. This is the modified Gomery's trichome, which again is used to identify what are called as the ragged red fibers or the presence of rod bodies. You don't see any such feature on this. The red colors that I showed you, those are not evident here. So this again appears to be normal, at least in the field that they have photographed. This is the NADH-TR, which are the oxidative stains, which again is a marker for the metabolic disorder. This again shows normal feature. There are no ragged blue fibers, rather the accumulation of enzyme activity in the fibers. So those features are not seen. They've done for the entire panel. So they have worked up for the muscular dystrophy. Since the child had elevated CK and calf muscle hypertrophy, one of the diagnoses could be muscular dystrophy. So they have investigated for the other proteins. The proteins look like the alpha sarcoglycan looks preserved. The beta sarcoglycan again looks well preserved in all the fibers. Dystrophin is again normally preserved. Dystrophin 2, C-terminal, and this is the N-terminal. All of them are well preserved. Myrosin, which is an extracellular protein, this protein is also well preserved. So to summarize the muscle findings, you have very mild variation in fiber size. There are no evidence of features to suggest the metabolic disorders or mitochondrial disorders, as in the oxidative stains were normal. MGT did not reveal any abnormalities. So on the whole, the muscle biopsy appears normal.
Thank you. So this child, we have seen all this muscle biopsy appears almost normal. She came back after 7 months, still complaining of pain in leg. Hypertrophy of calf muscle is still present, not tender. There is mild weakness still present. So that video. See, we have a video of the child which we can show you.
So what's interesting is that she appears to have not much clinical features of weakness, although I'll run the video here, which appears to show that show some weakness, and I'll point out exactly where. No, when she has to get up, if you notice that she's having a little bit of difficulty in getting up from supine posture, she gets up with a little bit of support onto her thighs. And when she sits, she appears to have the typical fall of a child with, like a kid with Duchenne. I mean, when she sits, she has that initial, I don't know whether you could appreciate that. She has that initial, the two things that looked a little suggestive of a muscle weakness is the fact that she has a little bit of difficulty in getting up. And when she gets up, she has this, needs a little bit of support to push herself up. And then when she sits down, she has that typical, the proximal weakness in the glutei just makes it fall down. And so that's all she has. Otherwise, she appears to have no obvious weakness and she's doing well. So here's a young girl with a high CPK, and this was her most recent investigations. So it's open for discussion now. Any comments? Any comments, Dr. Matthews?
Marison, this was obviously what you guys were thinking too. And following up what she said, if this is a secondary dystrophin deficiency, because I don't think this is a dystrophinopathy, this is not the clinical picture of a dystrophinopathy. It certainly could be a dystroglycanopathy, and I would ask you, on the MRI, did you look carefully at the cerebellum, and were there any cerebellar cysts?
Actually, no. Maybe I should go back, because only yesterday you were presenting this kinking of the cerebellum, and that's when I was thinking maybe we should look at it. Yeah.
So when you think about the dystroglycanopathies, the kinking of the brainstem you see in the most severe Walker-Warburgs, and then as you go through that classification of less and less brain involvement, one of the most mild forms, you can have white matter changes, and then you just see these cerebellar cysts, and they are, again, almost pathognomonic, and I can show you a picture on my computer later, but so they're just little teeny tiny cysts, and in this setting, that would nail down a dystroglycanopathy as far as I'm concerned. And then which gene is involved? As I said, there are now 9 genes and probably another 5 to be found. So which gene would be involved? You can't predict at that level, but I think the money is in that category of disease most likely. Another great case. Thank you.
Thank you. Thank you. Sorry.
Just a comment, as a pediatric neurologist, we're starting out, we gave the head circumference. Where is the percentile, please? That would have been, again, very crucial in recognizing this is not isolated muscle, that we've got a central and peripheral involvement, and so our whole approach is different. And you haven't given me the weight of the patient. So again, these are cardinal pediatric questions that separates us from adult neurologists. So please, I beg you, when you present next time, please include it. So I'm sorry for just, commenting on it, but I can't pass it up.
Thank you. That is very good, very important, because that's precisely why we get the postgrads to try and present the cases, because I think it's a learning exercise every time they present, and thank you for your comments. If there's nothing else, I think I've been told that I need to stop. There are 2 more cases, but we just reserved it in case we have more time, but we'll be happy to share anytime. Thank you very much, and thank Dr. E.S. Krishnamurthy for giving us this opportunity and inviting us over. Thank you very much.
Thank you.
Thank you, chairpersons, and thank you, Dr. Catherine Matthews. And I request Dr. ESK to give away the memento to Dr. B. Viswanathan. Thank you, sir. I request Dr. ESK to give away the memento to Dr. Gayatri Narayanappa. Thank you, sirs. We are now adjourning for the coffee.
The next section is on strokes in children, recent trends in diagnosis and management. I would like to invite Dr. Donna Ferrero to the podium. I do not wish to embarrass her with the extensive introduction we had yesterday. It will suffice to say she's Professor of Pediatrics and Neurology and Chair of the Department of Pediatrics and Physician-in-Chief of UCSF Benioff Children's Hospital. She is also the Director of Neonatal Brain Disorder Laboratories and Co-Director of Newborn Brain Research Institute at UCSF. I would also like to introduce and invite Professor Subhash Kaul to chair the session. He has had his MD, DM and PGI Chandigarh. He's had a stroke fellowship from the NIH USA. He's also the past president, Indian Stroke Association. His special interests are stroke epidemiology, genetics, and thrombolysis. At present, he is the professor and head of Department of Neurology at NIMHANS, Hyderabad. And over to you, sir.
Thank you very much for that kind introduction. First of all, I'm very grateful to Dr. E.S. Krishnamurthy and his team for giving me the honor and opportunity of chairing this very important session. I also want to really congratulate him for keeping stroke as a keynote lecture, because stroke, a lot of pediatricians don't even own this. As a matter of fact, in UK, stroke is not even given to adult neurologists. It has been shifted to geriatrics. So therefore, to have it as a keynote lecture is to give it its rightful place. And last of all, I'm very thankful to the organizers for keeping the air conditioner a little bit less today. It's very warm and cozy, and we're really enjoying. Thank you very much. Over to Donna for her keynote lecture.
Thank you very much. And that's a perfect introductory remark, because I think many people have no knowledge that stroke in the newborn is as common as stroke in the elderly. Now, stroke in childhood is a little bit less, and we'll go over those numbers. Just for a show of hands, how many of you in the audience have seen a child with a stroke? Okay, great. So maybe by the end of the lecture, everybody will feel comfortable in diagnosing this condition. So just a minute on definition. So we use the term perinatal stroke for stroke that occurs at or near the time of birth, neonatal stroke from in utero all the way through the first month of life at the end of the neonatal period. And then from that time to 18 years, we call it childhood stroke. And as somebody said yesterday, the child is getting older and older over time, so maybe this will expand. And then we have young adult and older adult stroke. But we're going to focus on primarily neonatal stroke and then some stroke conditions in children. So this is data from the International Pediatric Stroke Study Group. This is an organization that was founded by Gabrielle de Weber at the Hospital for Sick Kids in Toronto, and it now involves over 80 countries. I do believe we have enrollment from India as well. And you can see here that a third of the stroke patients are newborns. This is just age-adjusted rates for stroke in children, and if you look across between AIS is arterial ischemic stroke, HS is hemorrhagic stroke. And if you look across different countries, you'll see similar incidences for both, with cumulative rates at the bottom, with total rates, oops, sorry, this is going to be tricky. Total rates running about 5 1 in 20,000. So for neonatal stroke, we have 1 stroke per 4,000 live births. That's where we get the numbers from, basically kids who are presenting. So it's really, again, a condition of tip of the iceberg, because not all neonates will present in the newborn period with a stroke, and we'll talk about that delayed presentation. Neonates, in addition to having arterial ischemic stroke, will have sinovenous thrombosis as well, and you have to remember that greater than 50% of all childhood sinovenous thrombotic disease occurs in the neonatal period and can be associated with a number of findings like congenital heart disease, extracorporeal membrane oxygenation, thrombophilias, and chorioamnionitis. Here's a condition that you won't see at term, but you'll recognize later when the patient comes back, brought by the family because they're not using a limb. And so no clinically apparent perinatal difficulties, but then when we scan them, we see this curious finding of white matter injury that looks like a little bit like PVL, but it's a venous infarction, and you can see it's long-standing because there's Wallerian degeneration in the cerebral peduncle. Hemorrhagic stroke also occurs in the newborn, but is very rare, and they'll always present with encephalopathy, and most will have seizures. We don't really know the causes of this condition, but one thing we do know is that there are risk factors for this, and here again is modifiable risk factors. So if you look carefully here, post-maturity has a 7-fold increase in odds for perinatal hemorrhagic stroke. So something that's conceivably preventable. Preterm babies have stroke as well, and we often don't think of the preterm infant as having a stroke, but they do have strokes, and they have strokes that are very recognizable in their location. Their incidence is about 7 per 1,000 live births. It can occur at any time postnatally, more common on the left, just like in the neonate and the young child. But it's the deep structures that are actually showing the lesions, the lenticulostriate. And Dr. DeVries, in this wonderful paper by Manon Benders, showed that there is some risks like abnormal fetal heart rate, twin-twin transfusion, and hypoglycemia. And this is what it looks like. So instead of the big middle cerebral artery infarct, you're actually seeing an infarct in the lenticulostriate distribution involving thalamus or the caudate or putamen. So for clinical presentation, those are the ones we recognize. That's where the number 1 in 4,000 comes from. These kids will present with seizures. What kind of seizures? Always focal tonic seizures. When you see an infant who is just shaking their right arm and it's a seizure, you must do an imaging study to rule out a stroke. So this was a baby who looked apparently well, born at term, normal delivery, APGAR is good, but developed seizures at 8, focal motor seizures at 8 hours of life. And look at that huge MCA distribution lesion seen on the CT here. Now, delayed presentation is the harder one to pick up, and this is adding to the numbers, but we're not picking them all up. These are the kids who are called cerebral palsy. They come in with pathological handedness at a very early age. The parents will bring the baby in and say, my baby's not using their left arm, for example. And here's my patient with a very large MCA stroke. And this is what he looks like. And so he looks like a normal, healthy, happy boy, but the astute clinician will notice something here. Importantly, He's not looking at the camera. He has a gaze preference. So that tells us he has a homonymous hemianopsia. He's obviously fisting with that left hand, and he has paucity of movement on that left side. So this is a baby who has a left hemiparesis in the scan that I showed you. So delay presentation can be arterial or venous. With the arterial disease, we're more likely to see seizures and non-motor delay, and some history of acute perinatal factors if you dig for them. Whereas with periventricular venous infarction, that little white matter abnormality I showed you just a few slides ago, a very long time to make the diagnosis, and these are the kids who are more likely to have isolated motor findings, not cognitive abnormalities, and thrombophilias seem to be the same in both groups and are often normal despite extensive testing. How do we evaluate children with perinatal or neonatal stroke? We always do an MRI. We try to get an MR angiogram or venogram, especially if we're concerned about venous thrombosis. And EEG is always part of the workup because you get more information, not just seizure activity, but brain function as well, obviously. We don't often do echocardiograms, only if we see something on exam. We do metabolic workup because congenital disorders of glycosylation, which are rare, can present with stroke. Some organic acidemias lack congenital lactic acidosis. But it's important to work up both the mother and child. This is a disorder of the maternal fetal unit and can be thrombophilia. So you should wait, because if you want to measure some of the coagulation factors, you're not going to pick it up at the time of the stroke because they're going to be consumed. So you might get a falsely deficient abnormality. So genetic tests can be done in the nursery, but you should make sure you do the parents as well. Treatment of neonatal stroke I can cover in one slide because we don't really know what to do with this. And when we look at the data from the International Pediatric Stroke Study, you can see that the majority of the neonates here with whether it's arterial ischemic or cerebral sinovenous thrombosis. So here's AIS is in blue. Yellow is the venous disease, and some of them actually have both. Most of these kids are not being treated. And we'll go over the ASA guidelines and talk about classes of evidence in a few minutes. What are the risk factors for neonatal stroke, and are any of them modifiable? So in a very large study done by Yvonne Wu at UCSF from the Kaiser Permanente Health Maintenance Organization, she found a number of different odds in the mother that increase the risk, and those included a history of infertility, oligohydramnios, preeclampsia, PROM, and abnormalities like chorioamnionitis. So maternal risk factors important. During labor, prolonged second stage, any fetal heart rate abnormality, emergency C-section, and somebody brought up C-section yesterday, birth asphyxia and resuscitation all seem to be risk factors in univariate analysis. So when we're faced with this duality of risk, what do? We look for, try to look at the placenta, which in our hospital, as advanced as it is, it's very hard to get the placenta and actually look at it. But we encourage you to look for chorioamnionitis. We do work up for thrombophilias, but for the most part don't see them that often. We do metabolic workups. We make sure congenital heart disease is not in the diagnosis, and of course, rule out infection or any trauma. from the International Pediatric Stroke Study, we looked at all of our data, and we found in this large study that moms and their pregnancies appeared healthy. So there was no way to pick up from the pregnancy itself whether that mom was at risk, except if you kept in the back of your mind that the mom had a history of infertility. The neonates often required resuscitation, and some of them had systemic illness. And I know for many people, we think of newborns with stroke as being well babies who present with focal seizures. But about a quarter of them are not well and actually are pretty sick. And some of them did have cardiac and prothrombotic abnormalities. I showed you this yesterday. Risk factors for congenital hemiplegia can be determined on an MR scan. And the good news is that you can tell a family if there is an MCA infarct. If you don't see this signal, that child will likely be normal. That's great news that you can give the parents right at the very beginning, right at the onset. But if you do see corticospinal tract diffusion abnormalities, you're concerned about motor disability, and please involve the physios early. We at UCSF also looked for risk factors. We looked at a number of polymorphisms in the usual suspects for adult stroke, genes that regulate thrombosis, thrombolysis, cytokines, and vascular tone. We had 59 newborns with stroke, and we matched them to 347 controls and found no significant difference. And I think this, in part, is a population problem. You need large population studies to pick up some of these factors. In a meta-analysis of thrombotic factors, both factor 5 and factor 2 seem to come up a little bit more than anything else in a number of these studies. So they should still be in your mind, and testing should be done. And here's a very interesting gene. This is probably the one gene we know that causes stroke, not just in the newborn period, not just in the preterm period, but throughout childhood and in adults. And we need to look for this gene in adults as well, especially when there's hemorrhagic stroke. Doug Gould described this in a mouse and saw that heterozygotes that lived had poor encephaly. This gene causes a mutation in collagen secretion into the basement membrane and causes structural deficits in that vascular basement membrane. Linda DeVries nicely reported a case of siblings who had perinatal hemorrhage, and here you could see the hemorrhage on the ultrasound, poor encephaly with residual hemorrhage, and this is what the MRI scan looked like. They had mutations in COL4A. But the spectrum is really expanding, and I draw your attention to a beautiful neurological progress that Linda DeVries wrote in the Annals of Neurology this past year. And you can now implicate this gene and its partner gene, COL4A2, anywhere from fetal to a late adulthood. So this needs to rise to the top of the list. As I told you, the mutations cause protein accumulation, disrupting basement membrane, getting vascular abnormalities that not only result in sporadic intracerebral hemorrhage, but recurrent intracerebral hemorrhage. So very important to know about. How about outcomes? The good news is that most of the neonates do not succumb to the insult, but many of them, more than half of them, have cognitive learning disabilities, motor disabilities, and some of them have epilepsy. And in a number of studies, both from Yvonne Wu's Kaiser cohort, Adam Curtin's cohort, and Doris Trautner from UCSD, we can see that the long-term outcomes include hemiplegic cerebral palsy, epilepsy, learning, cognitive language abnormalities, behavioral and psychiatric, some visual. This is a huge societal burden that is basically not attended to. The good news on the flip side is that the recurrence risk for neonatal stroke is essentially zero unless there's an underlying disease like COL4A, like congenital heart disease. The also good news is that cognitive outcomes seem to be better despite these huge lesions, but if the child continues to have seizures, those children will have cognitive abnormalities. So it looks like plasticity plays a role here, but controlling epilepsy is critical and paramount to good outcomes. So I mentioned low recurrence rate for neonatal stroke, but stroke during childhood is much higher at 25 to 30%. And in a recent paper from Gabriele de Weber's group published last year in Annals of Neurology, when they looked at children with congenital heart disease, they saw that about 30% of them had experienced a stroke recurrence. So this is the population we really have to take care of, especially if they have an existing prothrombotic state in addition to their congenital heart disease. Now let me just spend a minute talking about the American Heart Association consensus statement. So we did this, it was a combined effort of many people listed on this slide. It was published in Stroke back in 2008. These consensus statements were also published in Chest, and you can get the paper online at the Stroke AHA journals and download these guidelines if you are interested. But let's talk about classes and levels of evidence, because this always confuses me, and I just want to reiterate as we go through some of the treatments that we recommend, what we're really basing those treatments on. Class 1 evidence says that the existing evidence that we have for a disorder is probably useful and effective. So we're looking for Class 1 evidence. In the slides I'm going to show you coming up, you're not going to see much Class 1. Class 2, conflicting evidence and divergence of opinion, especially about procedures and treatments. Class 2A is favorable, Class 2B maybe less likely. And Class 3 says that existing evidence and/or general agreement is that the procedure or treatment is not useful or may even be harmful. So let's take a closer look at this. So for perinatal, here we are with Class 2, no Class 1. Class 2 recommendations. An anticoagulation may be considered in certain situations, and we only anticoagulate those newborns who show propagation of clot. So that means you have to follow them either by Doppler, ultrasound, or MRI. It's obviously reasonable to evacuate a hematoma if the baby has high intracranial pressure, but most of the babies don't because they have an open fontanelle. It's unclear if removing the hematoma actually improves outcome because the numbers are so small. It's also reasonable to give the baby post-discharge folate and B vitamins if homocysteine is abnormal and an MTHFR mutation is present. So let's talk about a couple of other cerebrovascular lesions and see what evidence we have about some of these. So we'll talk about intracerebral hemorrhage. We'll go back to childhood ischemic infarction, venous thrombosis, and subarachnoid hemorrhage. So finally, we have Class 1 recommendations for the older child. So obviously, thorough risk factor evaluation is critical to any workup of any disease. And replacing clotting factors is another obvious treatment, as well as treating vascular anomalies that might have a bleeding potential, like a large arteriovenous malformation. But Class 3 recommendations say for children, a hematoma removal is not usually beneficial. And this is true unless there is massive increases in intracranial pressure, which don't necessitate removal of the hematoma, but actually necessitate an occipital craniectomy. Transfusions are not recommended to prevent hemorrhage due to sickle cell disease, and I'm going to talk a little bit about that. The etiologies for childhood stroke are more risk factors: congenital heart disease, sickle cell, dissection from a number of causes, meningitis, any coagulopathy, and embolism in a neonate, but we've talked about that. So here's an embolic infarction on pathology, large embolic MCA involving both the deep gray and posterior MCA distribution. Many of these emboli are coming from the heart in kids with stroke. Few strokes really need surgical correction. And the million-dollar question is, why do some of these children have strokes when they're embolizing and others don't? This child here actually had an atrial myxoma. She was 14. Class 1 recommendations for embolism include treating congestive heart failure. So these are just common sense management of a sick patient. Early corrective surgery if needed, and removing the atrial myxoma. But if it's a rhabdo, you might want to consider not doing that. Class 2 recommendations: reasonable to use low molecular weight heparin or heparin before you institute warfarin therapy in the setting of continuous emboli that you've documented on your cardiac echo. And you should continue this therapy for a year or two, unless the risk is actually removed, like in the case of an atrial myxoma. Sickle cell disease is a whole different category of disease. We see large vessel ischemic strokes, watershed infarctions. Many of children with sickle cell disease have silent infarctions, subarachnoid hemorrhage, intraparenchymal hemorrhage, and venous thrombosis. So it runs the whole gamut of stroke disease. There are class 1 recommendations, which are obvious. Again, treat the patient well, optimize hydration, oxygenation, and blood pressure. Periodic transfusions when there's an abnormal transcutaneous Doppler. Periodic transfusions after you've confirmed a bland infarct, and trying to keep that sickle hemoglobin below 30%, especially if you're going to try to do an angiogram to document disease. Class 2 recommendations include following the patient with transcutaneous Doppler frequently. Hydroxyurea is a good alternative if transfusion is not feasible. Some patients are actually undergoing bone marrow transplant when severe, and any revascularization surgery is really a last resort. Dissection we see, and we're seeing it more commonly in boys than girls. We see it after even very minor trauma. We've had kids who play this drinking game. I say kids, they're usually 18 years old, and they're throwing their shot of whiskey down their gullet and throwing their head back, and they end up with a vertebral dissection. We've seen dissections in cheerleaders and soccer players, and it just speaks to the ability of any spontaneous or traumatic mild, trivial trauma to cause a dissection, especially if there's underlying problems like homocystinuria. It's hard to diagnose dissection, especially if the patient presents a little bit late. You often have to do a fat-saturated MRI to see it. And in some cases, anticoagulation may prevent embolism, especially when you see a large pseudoaneurysm on the MRI. And here's a picture of this dissection on angiogram. You can see thinning of the vessel here. This is what this looks like, this large clot. And here's the endothelial surface there. And you can see an absence of the MCA on your MRI. The guidelines for dissection are really class 2. Begin with heparin if the child's older and it's bland. It's reasonable to continue them on therapy. At our place, we don't do that. And surgery is rarely considered, only if that pseudoaneurysm is really large and looks like it'll rupture. And a class 3 recommendation is basically against anticoagulation if there's subarachnoid hemorrhage, or if the dissection, instead of it being in the neck, is actually intracranial. Moya moya is something that we see actually at our hospital more commonly than we would like. We have a large Asian population on the West Coast. Moya moya, for those of you who don't know, is a Japanese word meaning hazy puff of smoke. Drifting through the air, very magical saying. And actually, that's kind of what it looks like here on the angiogram. It's this sort of puff of smoke, if you will, there. The term refers to the hazy appearance of those collateral vessels. And the risk factors that you should keep in mind are patients who have neurofibromatosis, any patient post-cranial irradiation from therapy for astrocytomas and the like, Down syndrome, and of course sickle cell disease is probably the #1 cause of moya moya in the non-Japanese population. Again, here's other lovely radiologic pictures of that puff of smoke, the vessels that are attenuated even posteriorly, and all the micro hemorrhages that you would see. These children often, if it's unilateral, do well with extracranial bypass. So the class 1 recommendations are for revascularization. Some indirect procedures work better for children. The indications for surgery are really if there are progressive ischemic disease or inadequate blood flow reserve. Class 2, using transcranial Doppler, but that's going to be insensitive, and you should realize that. And any technique that can measure blood flow accurately could be useful. Some patients are put on aspirin if they're not, especially if they're not surgical candidates, and obviously you would want to minimize pain and anxiety during any procedure for a child. So when to anticoagulate? Again, we're dealing with very limited evidence. It has not been studied well. There is a trial in the United States right now, and I think it does involve some extra North America sites as well to look at anticoagulation in the newborn. There's also a trial to look at TPA for ischemic stroke in babies or children greater than 2 years, but that data is not in yet. So we're stuck with Probably yes and probably no. So the probably yes is recurrent embolism, high risk of embolism, dissection if it's not intracranial, any severe hypercoagulable state, and venous sinus thrombosis. This is children now, not neonate. And probably no, thrombocytopenia, bacterial endocarditis, sickle, big infarcts because you don't want to turn a bland infarct into a hemorrhagic one, and obviously a hemorrhagic lesion. So in conclusion, I hope that I've impressed upon you that stroke through childhood is actually common, and stroke in the neonate is as common as stroke in the elderly. Hemorrhage can be caused by many things in children, especially AVMs, tumors, and thrombocytopenia, but we don't really know the cause in the babies for perinatal hemorrhage, except for COL4A1. Causes of infarction can be from the heart, from hemoglobinopathies, or dissection, so we have to think about all of those things in our workup. Treat any kind of risk factor to prevent recurrence, like infection. And there is value of these common treatment options when we're uncertain. The real issue is that we know so little about stroke in children, and that there's so little funding that goes toward this disease in children to study it adequately. And you can't take a big brain and make it into a little brain, because the pathophysiology is absolutely different. So until we can really heavily investigate these disorders, we are stuck primarily with class 2 and 3 level evidence, kind of running by the seat of our pants on this and hoping that we can eventually come up with large-based clinical trials that can help us determine how to treat these children. I just want to acknowledge the International Pediatric Stroke Study for some of the data that I showed you. Gabrielle de Weber, who's the leader of that, Heather Fullerton now as well, and some of their data I showed you along with Yvonne Wu. And Steve Roach, who led the American Heart